thanks for the introduction, Sana. I'm just really thrilled to be here, at least virtually, talking to you guys today. As Sana told you, I'm going to be sharing some sort of research as well as some practical tips around autism supports early in development. So a couple of just disclosures. As Sana mentioned, I co-developed the social ABCs. I also co-developed the 2019 CPS practice statements along with Lonnie Weigenbaum. So I'll be talking about both of those. I don't receive any royalties from their use, but you do need to know that I was involved in that work. And also just a note about terminology. I'm going to use both person first and identity first language somewhat interchangeably to reflect the range of preferences in the community. So the outline for today, I'm just multitasking here, so I don't cover my own slides here. We're going to talk about autism early in development. What do we know about the earliest signs? I'm going to share some guiding principles of very early supports or early intervention, and really how do we bridge from what we know about early signs to early intervention. I'll give you a little bit of an update about the state of the research. I will talk about the social ABCs, which is our intervention developed here in Canada. A few tips for families to try at home, and then some take-home points also for clinicians. So first of all, we know that babies and toddlers are unique little people, and they really have sort of a series of particular tasks that they're working on in terms of their developmental progress. So in the toddler years, little ones really focus a lot on learning about how to control and move and share their attention. They spend a lot of time learning how to regulate their emotions, how to build relationships with the main people that are in their lives. They learn a lot about social routines and play and, of course, communication. So there are other areas of development that little ones focus on, including sort of motor development and learning about the early academics and sort of practical skills. But we're really going to focus on these areas in the blue here. So we've talked about toddlers in general, and what does autism look like in toddlers particularly? So this is work that some of you may be very familiar with. This is work that Lonnie took a leadership role in terms of really kind of understanding how autism develops from the very first months of life. And we call this the Canadian Infant Sibling Study. It started in about 1999. And we work with we start out with two groups of babies that we work with. So one group are the babies who have a sibling with autism, and the other group would be babies who don't have a sibling with autism. And we start working with those little ones and learning about them and doing assessments around 6 to 12 months of age. And then we follow their development at multiple time points. So we see them at 6, at 9, 12, 15, 18, and 24 months. And then we see them again at age 3. And at age 3, we do sort of a fairly standard clinical assessment to see whether a child meets criteria for a diagnosis of autism. So some of those baby siblings do, many of them don't receive a diagnosis of autism. And really what this research helps us understand is when we look at those children who have autism at 3, what did we know about them when they were 6 months old or younger? Did we learn anything that could help us understand how autism develops and what might predict autism later on in life? So we work with younger siblings, as I said, partly because we know that those little ones do have an elevated likelihood of having autism themselves or sort of related social communication challenges. It allows us really to see a variability in presentation across all sorts of areas of development. So language, nonverbal skills, motor, attentional skills. It helps us look at the strengths as well as the challenges that those kids have, and really allows us to look at sort of very early signs of what might become autism later on in life. Not surprisingly, I'm sure to anybody here, it really is parents who notice the first things when we're working with these babies. So around 6 months of age, parents are telling us that they see differences already in their baby's ability to track objects, which probably relates to attention, and then in kind of reciprocal back and forth babbling and vocalizing with their caregiver. By 9 months, parents are reporting lots more differences, so sort of inconsistent response to name, difficulties with that reciprocal babbling, some differences in eye contact, social orienting, regulating emotions, and sensory behaviors. And then as clinicians, we're sort of noticing things around 12 months of age. So we work with the babies in an assessment context. Baby might be sitting on the parent's lap, and we do a test called the AOC, where we sort of do various different things, like we play with the babies and we call their name and we draw their attention to things and see how they interact. And what we notice from the AOC is that at about 12 months of age, we start to see significant differences between those babies who are in the group that we call the elevated likelihood group, in terms of those who go on to have autism versus those who don't. So around 12 months of age, we're starting to see sort of early signs of kids who then go on to have an autism diagnosis at 3. And just to be really clear, none of these are sort of definitive. One sign doesn't tell the whole story. And we really generally need to see multiple signs in order to predict an autism outcome. And these are all just sort of talking more about increased likelihood. So none of these are definitive signs. But we do see at 12 months that those babies who go on to have autism do have differences in terms of orienting to name, that reciprocal babbling that parents were telling us about already, differences in eye contact, social interest, some difficulty with transition start to come in, and kind of insisting on playing with a particular object or sensory areas of play. So in 2019, we sort of collapsed all of this information together. Again, Lonnie took the lead here in developing some guidelines for the Canadian Pediatric Society to really make sure that pediatricians know what those early signs are, so that when they're seeing children in their practice, they can be keeping an eye on those kids who might be at elevated likelihood of having autism. So again, we sort of talked about those differences from early in life, around 6 months of age, in terms of differences in social attention, smiling with their caregiver, responding to name, gestures. As kids get a little bit older, we might see them starting to engage in play in a repetitive way, difficulty learning language and using gestures. And then we really made a very strong recommendation that anytime parents bring forth concerns, or if there's any evidence of developmental regression, that the pediatricians really need to take that very seriously. So you'll see that a lot of these domains are the same of those areas that I was talking about in toddlerhood that are really, that toddlers kind of tackle and work on very early in life. So given what we know about early signs of autism, or sort of early things that can predict an autism outcome, how does this inform what we do and what interventions we engage in? So I'm going to just sort of lay the groundwork around very early intervention, because I think there's some very important kind of guiding principles that we really have worked towards meeting before we develop an intervention in this young age group. So we want interventions or supports and service to be evidence-based, but we also sometimes have to innovate, because when we started this work, there wasn't a lot of published literature on sort of the evidence supporting very early intervention in these kids with sort of emerging autism. So we sort of have to use the evidence, but then also be innovative. We want interventions to be child and family centered, culturally safe. We really want the targets to be meaningful. And what I mean by that is we want them to be meaningful to the child, to their family, and also within the context that they're living. So sort of culturally safe and informed that way. We want the targets to be developmentally sensitive. So thinking about kind of building skills that are foundational or pivotal early in the child's learning. Think very carefully about the developmental sequence. Interventions should be naturalistic for these toddlers. And we really emphasize working in a positive learning context, so that the child can learn very, very early in life that these kinds of interactions are fun and positive, and kind of build on the child's strengths and motivation. So in 2015, a fairly important paper came out that really talked about this group of interventions called naturalistic developmental behavioral interventions, or NDBIs. And really what the authors talked about in this paper is how NDBI approaches sort of bring together the best of all the world of naturalistic interventions, developmental and behavioral programs, into this kind of group of interventions And since that time, some research really has shown through sort of groups of studies that this is probably the type of intervention that has the best supporting evidence, particularly in the toddler age group. So let's dig a little bit deeper into these NDBI interventions. I will just note that most NDBIs really do emphasize those foundational or sort of pivotal learning targets that we talked about early on around social attention, regulating emotions, building relationships, social routines, and play, as well as communication. So, you know, we sometimes talk about NDBIs as if they're kind of a one thing, and they really aren't. They're just kind of a large spectrum of different kinds of sort of specific types of NDBI approaches. So they really vary in terms of who delivers the intervention. So it might be a therapist, it might be parents, it might be a combination thereof. They vary in terms of what the targets are and also how sort of intensive they are versus targeted, working on just a couple of key core domains versus kind of a lot of different areas. They differ in terms of where they're delivered. Some are center-based, some happen in home, some have a little bit of a mixture of both. And then how they're delivered. So some are delivered in person or virtually or through a hybrid of both. And then some involve, particularly those parent-mediated interventions, involve coaching parents, which can take place live, kind of in the moment, or via video feedback. So there's lots of variability when you kind of hear the term NDBI. It may mean any version of these things. So I'm going to focus a little bit on these caregiver-mediated approaches. Again, language matters, and sometimes these approaches are called caregiver-mediated or parent-mediated or parent-delivered or parent or caregiver implemented. Those kind of all generally mean the same term, the same thing. They are different than sort of those psychoeducational or parent education sessions, and I'm happy to clarify that if that's not clear. There's just sort of been, in the past 13 years or so, a lot of interest in these NDBI approaches, and particularly the caregiver-mediated ones for toddlers with emerging autism. And there's now been sort of a good handful of randomized controlled trials, so there's very rigorous research designs since, as I say, in the past 13 years or so, showing gains in terms of children's communication. And I'm just on the right here going to list those references, and if anyone's interested, gains in terms of social engagement, social skills or interaction with others, play skills, sharing emotions, and then some sort of reports of parent effects like increased synchrony with the child, reduced stress, and parents reporting feelings of empowerment. So I do just want to share a Canadian example, which is the Social ABCs, which I've referenced already. This is the program that I co-developed with Susan Bryson, and also along with Lonnie Zwigenbaum and Isabel Smith. We've been working on this research for several years now. So the Social ABCs is a caregiver-mediated NDBI. It's for toddlers with autism or emerging autism, ASD, and particularly in that kind of age range from about 15 months to about 3 or 3.5. It's play-based and routines-based. Families learn about the ABCs of learning, like how children learn. We use a very active coaching approach. So parents are coached in the moment as they interact with their child. And we also have manualized curriculum, so a parent manual. And our approach would be described as targeted in that we really focus on two very core areas of early development, one being sharing positive emotions between the child and the caregiver, and the other being developing meaningful directed communication between the child and the caregiver. So what does the Social ABCs look like? There are kind of two ways of delivering the Social ABCs now. One is a 12-week model, which is all individual work. And then we now have a 6-week model, which entails some group work. And regardless of which kind of model a family participates in, they all receive these core components. The first one being didactic learning sessions where parents meet with coaches and facilitators and kind of learn the material using the parent manual. That can take place either individually or in a small group. And then everyone receives individual coaching while the caregiver plays with the child. They're coached in the moment, as I described. We usually tape record everything, and we use video recordings to look at child progress over time and parents' sort of ability to learn and kind of find ways to use the strategies in their day-to-day lives. And then we do ask parents for feedback about how they found the intervention. And in some of the studies, we've also used clinical assessments or parent questionnaires about the child's development. So this is just an overview of kind of where we started and where we've come to in terms of the research as well as practice with the social ABCs. In 2007, we started to develop the intervention, and we ran a small pilot study. Following that, we ran a larger randomized control trial across sites to show sort of the efficacy of the program in these ideal research constrained contexts. We then conducted some training of early childhood educators using our social ABCs techniques. We've now run a second randomized control trial where we started with kind of helping children enhance their attentional skills before they started the intervention. And that work is being analyzed and written up now as we speak. In 2016, our group did a large community demonstration that showed that the social ABCs works when it's delivered through a community provider. And that work was with McMaster Children's Hospital here in Ontario. And we worked with almost 200 kids. We then evaluated the group model, and COVID struck right in the middle of that study. So we were able to look at whether there were differences when we delivered the coaching virtually versus in person. And we found out that virtual delivery works almost identically as in-person coaching, which was great to learn. We developed some community training, global training initiatives. We now have a lot of implementation going on, which I'll talk about in a minute, as well as a virtual group-based randomized control trial to really kind of understand how that group model works compared to a sort of a parent education intervention. So just pulling it together a little bit in terms of clinical delivery, we have some global partners that are delivering the program clinically. In Ontario, we've now trained staff at 10 different community centers or community service agencies who are providing the intervention. And then in the province of PEI, it's the social ABCs is available provincially for toddlers who are waiting an assessment for autism, which is really great. So they get it nice and early. And then in terms of research, we have research going on, this group-based randomized control trial, as I mentioned, in Alberta, Nova Scotia, and Ontario. So what does the research tell us? As I said, we've done quite a few studies to date, and overall it's telling us that the toddlers make significant gains in terms of their responding to their caregivers, initiating language, as well as sort of their language scores on standardized assessments. We see gains in terms of the baby's ability to orient to their caregiver and parents and children smiling together. Parents learn the skills that we're teaching them, but they also tell us that they're feeling sort of empowered, and they talk about feeling self-efficacy and satisfaction with the program. In some contexts, we do see reduced stress for the parents, but it just very specifically, that seems to work best when families are seen in person in a small group setting. We've had really great feedback from families. I won't read all of this, but really comments around helping us kind of helping the parent understand their child and kind of really increase their confidence in interacting, which have been really important for us to hear from families. So, we've learned a lot about NDBIs, and there's a lot of research that's gone on in the past 13 years, but there is still a lot of information that we need to understand more. So as I mentioned, we sort of can say that there is mounting evidence to support NDBI approaches, particularly with toddlers, but the research is still, there's methodology in these research studies that's still considered a little bit biased. So an example might be most of the social ABCs research involves me as a researcher, and I'm the developer of the program. So really sort of to remove that bias, we need to get some research going that doesn't involve me, and that involves community partners who've been delivering the social ABCs beyond sort of our training opportunities with them. And we really would ideally have some comparative randomized controlled trials where we compare a program like the social ABCs to another parent-mediated NDBI to sort of really see where the differences lie. We really don't know yet which specific approaches work best with which families and which particular children. We don't know yet what are some of the barriers and facilitators to access. We're just starting to understand that a little bit more. I have a graduate student, Erin Dowds, who's really been digging into the barriers and facilitators for families, which will be really important for us to understand. We don't know yet what adaptations are needed across for cross-cultural relevance. We have translated the Social ABCs manual into French, and the program is being delivered in Ottawa in French, which is amazing. And we've learned some things there about some small adaptations that have had to be made. And in our global partnerships, we're learning about adaptations as well, but we haven't studied that as systematically yet as we would like to. We don't know yet what the long-term outcomes are, so we really have the the purpose of these parent-mediated interventions is to allow the parent and the child to kind of interact in these enhancing ways throughout their day in a comfortable, naturalistic way. So we're certainly not asking parents to become therapists. We really don't want that to happen. We just want to sort of arm parents with little tweaks that they can use to kind of enhance their child's development. And the premise for that is that a child then can get sort of lots of access to comfortable, natural intervention throughout the day, which theoretically has the potential to have big long-term outcomes or big long-term impact, but we haven't measured that systematically. And we really don't know yet if there are risks that we need to understand more and how we can mitigate them. So these are just some tips, a little tip sheet that I had put together for families. We talk about 2 different steps that families can take. This is step 1, which is to really observe your child, watch them. What do they like to play with? Notice what are those characteristics of the play and the activities that the child likes, and then engage, get involved, kind of building routines based on those very specific characteristics that your particular child enjoys. So there may be a game that you would expect to play a particular way, but you notice your child really likes to, roll some of the toy play materials towards you, like take advantage of that and you can build that into a playful routine. How then can you use those playful routines to build those positive relationships and communication? This is step 2. This is a little more awkward. It doesn't fit as well, but essentially sort of think about these 3 stages. So you want to be establishing that fun routine once you really know what it is that your child is interested in. You get that routine going, and then you're going to pause just for a moment and you're going to wait for a message from your baby or from your child. What do I mean by a message? It can really be any of these things. So something like leaning towards you, looking up at you, pulling on your arm, making a sound, smiling, moving someone's body, moving their body. So anything that gives you a hint that your child wants that interaction to keep going, and then the parent will just keep going and kind of keep going around that routine as long as everybody's still having fun together. Some take-home points for providers. It's really, really important to partner with parents. So thinking, really listening to them, supporting them, and empowering them. For parent-mediated interventions, we need to think very carefully about fit. So when is a parent-mediated intervention a good fit for a family? Is it right now the right thing for a particular family who may be juggling multiple demands? If it's not the right time for that family, we need to be armed with alternatives so parents don't feel guilty if they're not taking these things on. We need to respect the evidence and build the evidence, but we may sometimes need to innovate and build new evidence. These parent-mediated interventions, one of the advantages of them in a public health system is that they are a little bit more resource efficient, and they also really build on that important relationship between a primary caregiver and their little one. So we can find ways to increase some efficiencies, like maybe with virtual coaching and things like that, but we also have to be very careful that we don't build in so many efficiencies that that we start to compromise the effectiveness or the acceptability of the program. And just be really thinking carefully about ways to intervene as early as possible when those first signs emerge, so that families can be armed with the skills and confidence and kind of that sense of agency as early as possible. We're very motivated to find ways to deliver this kind of program early in development, maybe like they're doing in PEI while kids are on the waiting list to receive a diagnostic assessment. And I do, of course, need to acknowledge my team, who are amazing. And you met Lonnie and Sana today. If you haven't met them before, they really have played a seminal role in this work, along with my other colleagues here on the screen and our funders. And I just am very grateful to have your ear today and happy to take questions.